Okay, good morning, everyone. Can you hear me? Yes, okay, awesome. Welcome to this session, Reimagining the Future of Health. So we can go really far in our minds with what that could potentially look like. I'm really excited to be here with all of you today this morning. In this conversation, we're centering equity, we're centering women and gender diverse people's rights and Indigenous self-determination. So for myself, I'll introduce myself for a moment. I'm a second generation Dutch settler living on unceded Indigenous lands, use the pronouns she and her. Kanakagwe Nation is the custodian of the land that I live and work on. It's where I'm raising 3 children, very proud to have had them, born with the support of midwives, who identify as Black with Maasai and Dutch ancestry. The place where I live is also called Montreal. I have been working with the National Aboriginal Council of Midwives for about 8 years, and I'm so pleased to be here with some of my council members, some of my colleagues, and some new people that I haven't worked with before. So I'm excited to hear from you. I'm going to just do a round of introductions for the panelists. So Sarah will start with yourself, and then Mandy, and then for you, Meredith. And then I'm not sure if there's a recorded introduction for your colleague. No, okay. And then also Ellen as well, who is joining us virtually. Good morning, Ellen. So Sarah, do you want to start with introducing yourself?
Sure. Good morning. Bonjour. Sarah Wolf. So I'm Sarah Wolf. I'm the director for the Indigenous Innovation Initiative. I'm a Anishinaabe. I am from Brunswick House First Nation, which is up in Northern Ontario, between Sudbury and Sault Ste. Marie, and the ancestral territories that my family come from is between Hudson Bay and James Bay. And in that territory in between, my great-grandfather was a trapper, and my great-grandmother was a midwife. I worked as a midwife and a primary healthcare provider for just over 20 years. And recently, as 3 years ago, made a shift out of midwifery into social finance. My work as a midwife and as an Indigenous midwife in a major urban center in Toronto allowed me some really privileged opportunities to work with Indigenous families and other families, supporting them to really achieve their full potential. But I grew increasingly frustrated that, you know, the many challenges I was seeing within those Indigenous families and pregnant people around food security or housing security, around violence in the community, poor health care outcomes, terrible access to services within the healthcare system, and poor treatment and racism within the healthcare system, and all of these different elements I became increasingly frustrated with the idea that poverty was at the root of so many of those things. And so that's what prompted me to shift up into an innovation platform and do social finance. And so we joke now that I'm the midwife of innovation, because really I'm still helping people to birth new ideas in this innovation platform. And I'm getting to, support people to birth and take care of these new ideas, their new babies, as new businesses and new enterprises and new projects, but the hours are much better.
Kwe Kakina, my name is Mandy Commanda. I am Algonquin Anishinaabe from Kitigan-Zibi, which is just north here of Ottawa. I am an Indigenous registered midwife of Quebec. I used to be a registered midwife in Ontario until I decided to make the move back home. All of my family lives in Kitigan-Zibi, so it's very important for me to, or it has been always important for me to return home to provide my services to the community of Kitigan-Zibi and the area of Maniwaki for recognized Indigenous people of the area. So I just started practicing about 6 months ago, after a few years of figuring out the red tape. And I'm very excited and honored to be providing care to the Indigenous families of the area. I studied in Ontario, did all of my not my preceptor, but my placements in Ontario, and did that all by myself while my family stayed at home and waited for me to return. So I'm honored to be here today to discuss the issues that Indigenous people in my area face, and most likely in all other Indigenous communities as well. Thank you.
Thank you so much for that, Mandy. Ellen, do you want to introduce yourself?
Sure. Can folks see me? I'm not familiar. Okay, I can see myself now. Thank you. So yeah, hello everybody. My name is Ellen Blay, and I work at the Association of Ontario Midwives as Director for Indigenous Midwifery in Ontario. So we support vision-wise 133 First Nations across Ontario. I am from Oneida Nation. Oneida Nation of the Thames specifically. The Oneida Nation spans across what used to be our nations without the borders of the U.S. So into the upper New York State and across into Lake Erie. And so my ancestors crossed Lake Erie and set up a settlement just southwest of London, Ontario. And so I'm one of the 60 scoopers. So I was apprehended at birth from my birth mother, who is so her name is Many Flowers, and her mother's name was She Who Carries Flowers, and that led me sort of on a long circuitous path to becoming a midwife, because I sort of looked around. I'd had 3 children of my own, and looked around Toronto and thought, there's no one to support women who are having babies, and the apprehensions that are taking place, they're on their own. So, I helped set up a practice in Toronto called 7th Generation Midwives of Toronto. Sarah Wolf is here on this panel and was really integral as well in setting up that practice. But I moved on and went through midwifery school and became a midwife, and then worked in child welfare as a midwife, because really what I was doing was going back to my roots and figuring out who was my mother, who was I in that process of being apprehended. So that's what led me to the work that I'm doing now, which is working in Indigenous midwifery in Ontario. What we had done back in about 2014-15 is advocated for an envelope of funding with the Ministry of Health that would then be able to support communities to start Indigenous midwifery practices. So that and a lot of other areas of Indigenous midwifery in Ontario, our team is working on at the association. So I'll leave it there. Thank you.
Thank you so much, Ellen. Meredith.
Sure. Good morning. My name is Meredith Holt McKenzie. I am a Senior Gender Equality Advisor with World Vision Canada. I also come from Northern European stock, so am a settler here also in Canada. I'm privileged to be on this panel with my midwifery colleagues who were, not these women specifically, but other midwives were very instrumental in the birth of my 2 boys. I live outside of Ottawa on a farm in Balderson, which is on unceded Algonquin and Anishinaabe territory. And I'm privileged to work that land. It's an organic farm, so I feel in some ways that we are making amends for some of the more harmful practices that go on in agriculture. After this panel, I have to go home and move a herd of cows onto grass. So I won't be staying much longer after this, which is unfortunate. I'm also representing, so as I said, I'm from World Vision Canada. I've been working in international development for over 25 years, and I'll be joined today by my colleague from Tanzania, Muvano Malimbwi. She'll be joining us with pre-recorded comments on the panel. It's not that easy and steady sometimes to join from overseas, so we'll be bringing a bit of a global perspective on the panel, and hopefully can do justice to some of the experiences of women in Tanzania. Thank you.
Yeah, great. Thank you so much, everyone, for those great introductions. So let's get started. We have a couple of things to talk about. First, we're going to talk about some key gaps and focus areas of everyone's work. I wanted to just take a quick moment to thank Shanice Steele this morning for setting the stage with your words, sharing about the importance of community and the impact on your life of having had access to knowledge keepers, elders, ceremony. Those are resources and supports that are needed for the health and well-being of youth, of families and communities, and specifically in the sphere of midwifery work and Indigenous midwifery work. It's essential for pregnant people to have access to these services and supports. The work of midwifery, Indigenous midwifery, is about restoring safety, bonding, connecting, community, identity. It's the work of nation building. It's the work of sovereignty. It's the work of disrupting these systems of oppression and routine practices of family separation, practices of birth evacuation, child welfare, incarceration. I think we're all familiar with these issues. So I'm going to open this up to all of the panelists. Maybe Mandy, you want to start first, and we can kind of flow from there. But from your experiences, can you talk about some of the current major gaps or key priority areas that we need to meet so that we can move forward in a way that centers equity and the voices of women and gender diverse people in healthcare?
Yeah. So working in the area that I do, and I mean by geographical area, there seems to be a lot of inequities in regards to care that the Indigenous families face when seeking out obstetrical care. And one of the biggest issues in my area is the language barrier. The Indigenous folks in my area were very Anglophone, living in a very Francophone area. So it's quite challenging for clients to actually access care that they understand. So I do deliver babies outside of a hospital that's just 45 minutes north of Maniwaki, and the nurses there are very French. They do try and speak English, but it's a very big language barrier. And what my clients are facing is, this language barrier that they perceive as racism because they're English speaking, they're First Nations clients. So being hired now as a midwife in the area, I'm able to provide that. Although I don't speak French very well, I understand very well, but I am able to provide that translation services for them so that they're better understanding. They're understanding their care, they're understanding what the nurses are trying to say to them. The doctors, thankfully, are very bilingual, so that makes it easy for them. But now also I'm taking clients into my own care and providing them with culturally safe, evidence-based care so that they are more empowered. Now, when they're going into their births, they feel more informed, even as, second, third, fourth time moms, they're saying, this is information that I've never heard before. So that in itself, in my area, geographically, was a very big issue. Like I said, the language issue was really big. So being able to provide that support for them, even from clients who are still in doctor's care, they still come home, and I'm providing them with the postpartum care. So there's more support for them. There's more, at-home support, breastfeeding support, and just their questions being answered in a proper way, in an informative, educational way. And that's been my role so far in my community. And of course, I hope to expand on that in regards to, a broader education for, the whole of Maniwaki, but that's a goal that's later down the road. But that's the biggest inequity that comes with it in my area.
Thank you for that, Mandy. Sarah, do you want to comment a little bit on some of the key gaps
I mean, I already mentioned a whole bunch of gaps in my introduction, right? This is why I shifted into social finance, working to support economic reconciliation and to address poverty, because I think that's one of the biggest gaps, is just having the means to be self-sustaining and feel empowered so that they can access the safety, the security, the healthcare, and the services that they need. When I was practicing midwifery, I think when, kind of in the last few years of the work that I was doing within 7th generation midwives in the Toronto Birth Center, was really trying to look at what are the opportunities for system change. And, I heard you say, like, if you're not part of the problem, you can't be part of the solution. And so looking at the midwifery practice and what were the different partners that we could align with, and creating a community of providers to wrap supports around families, and those system level kind of relationships that could be built so that we could build a system of trust. The families didn't have to go around and try and access all of those different things in a really uncoordinated way, but rather, would be able to access it, not necessarily all in one spot, but in a way that was complementary, rather than everyone trying to address the same issue. Oh, they don't have a house, so everyone's trying to fill out a housing application for them. But really what they need is much more complex than that. System change, I think, requires a lot of system level innovation. And we need to start bringing people together into the circle so that we can start recreating what those systems are. We all know that, barriers for marginalized or, vulnerable people, and I struggle a lot with those words. They're just people, but the systems that exist are racist. The systems that exist are problematic. And so how do we bring people together to start looking at what is the system level change, and how can we be innovative and creative to build a new system that actually meets the needs of a broader spectrum of the population, and in fact can be inclusive for everyone.
Systems level change. So you've sort of like catapulted us ahead to the last area of questions. No, which I love. But you also, you're also talking about these systems of oppression. And I think it's really helpful to just name that at the beginning, right, of what it is that we're actually talking about when we're trying to think about a different future. Ellen, do you want to share some of your thoughts?
Sure, thank you, Alicia. One of the areas, you might see my eyes going down because I'm referring to notes that are trying to coordinate one screen. So in my area of work, it is more on a systems level. One of the things that I've seen is a lot of resistance from many sectors to collect data from Indigenous communities. And we know that there's OCAP principles, there's principles that in ways of going about and doing that are community-based, but there's been little effort to actually invest in proper data collection of Indigenous midwifery practices. And having them define what their indicators of health are for themselves. And so without this kind of data, we can't actually create rationale for additional funding, for policy change and development. So that's one of the system areas that I see that, we've been asking for over 10 years to have this kind of work done. And there's just only just beginning to think about how important this is for Indigenous communities to define for themselves what they want kind of data they want to collect. Another thing is that I don't see myself or anyone else like myself reflected on very many tables everywhere, committees and things like that. So one of the things I've done recently is worked on when we go into negotiations, for example, with the government, to have an Indigenous facilitator for those negotiations, so that there'll be more of an equity of balance of voice on those kinds of tables. And also one of the areas I think is a big gap is understanding by governments and funders that we have gone through centuries, hundreds of years of oppression. And so the concepts of like low-hanging fruit doesn't resonate in an Indigenous community that doesn't even understand what midwives do, because we've been evacuated out of birth for decades and for hundreds of years, really. And so with the medicalization of childbirth and the policies around evacuation, it's getting back into those communities. And first of all, understanding why midwifery is valuable for the community, but also these kinds of projects. How do you undo hundreds of years of colonization in community to begin to get to the point where there's an understanding of what how important midwifery care is. And on the other hand, for the governments to understand that low-hanging fruit doesn't happen after so many years of colonization, and that we need to slow down and think about how we can work with Indigenous communities that make more sense for the community. And so that midwives and the women in the community are the decision makers. The government should be coming to us to say, what can we do for you? Not us having to beg, find data, and figure out ways and rationales. These are larger understandings that need to be undertaken and understood.
Yes, thank you so much for that, Ellen. Meredith, take us to the global stage. Can you comment a bit on some of those gaps and key areas of focus?
Yeah, one of the reasons that we really wanted to speak today was thinking about the voice of women and the fact that cultural bias and discrimination and marginalization isn't something that's unique to Canada. It exists globally for sure. And there's really good evidence that that there were pre-colonial birth practices in Africa across the continent that were very empowering of women. But over time, women-centered birth practices where women's voices, the birthing woman's voice was elevated, have been overtaken, she's been moved sort of to the outside. She's been silenced and almost gaslit around what the experience is that's going on in her own body. And systems intersect at all levels in women's lives. They intersect at all levels in our lives, and certainly that is the case in Tanzania. My colleague Mugano is going to be speaking to that in a little bit. But I think one of the things that's really important that she speaks to, and that I've witnessed also, is this internalization of inequality, this internalization of cultural norms of behavior, when to speak, how to speak, to whom to speak, and that there's a lot of governance and normative behavior around how a woman is allowed to express herself. And this carries over, also into the home that she creates with her partner, and the degree to which she values herself in that relationship. In most cases, but not all, he values her. And so that the very, very patriarchal norms exist in those marriage relationships. And then, that carries over also into facilities. And so women are blamed for showing up too late, not coming often enough, not coming too early in her life. So she's too young to be having a baby. And at all points getting blamed for things that are completely beyond her control. So all of this leads to, women and girls not speaking up when they know that there's things going wrong in their bodies, and they have a challenge to be able to say something about that. So I'm looking forward to Movana when she can speak a little bit later. I will just make a comment as well, though, that when I had my second baby, I ended up being in the hospital, but with a midwife, and the obstetrician, because there was an automatic transfer of care that I wasn't aware of until I got to the hospital, said to me, well, your uterus is dysfunctional. It's just going to be the same as the last time, which was 72 hours of labor and a C-section. And I was like, no, this is not the same as the last time. This is totally different. And I don't know where that voice came from, because I'd gone into that labor really worried that in fact it was going to be just the same as the last time. And so I feel as though the fact that I was able to say that is really indicative of my own cultural background, my own ability to be able to express myself and know that I have a voice and my voice is valued. That isn't the case around the world. So
you're reminding me of the current co-chair of NACM, Claire Manchester. She often talks about within her role as an Indigenous midwife, really talking and teaching and working with families and with younger children about their rights and recognition of their rights and their identity. So this kind of flows into our next section. We're going to talk about identity erasure, which is quite the opposite of that in the healthcare system. I wanted to ask, Mandy, I think I'll start with you again, if that's okay. Yeah. Can you talk about a time when you yourself or you witnessed someone not being seen or heard by a medical staff and how that affected you?
Yeah, I feel like there was a case where not too long ago where a woman came late into my care and had not had any follow-up during her pregnancy. She was very educated though, she'd take her blood pressure every once in a while, and she took care of herself, but came to me late in care, and she was a VBAC client, so vaginal birth after C-section. And we attempted to do a VBAC here at the birth house here in Gatineau, and she just had a very hard time, and so we transferred into hospital. She was requesting an epidural, so we went in, and it was really hard for the medical team to understand that she was making these choices for herself. She made she was advocating for herself, and of course, she had a higher BMI. This baby was really big, but she absolutely wanted to try for a vaginal birth after C-section. She declined. Of course, she didn't do most of the tests during her pregnancy. And to try and explain these things to the medical staff when we got to the hospital was, it was really, how do I say it? It was just really daunting to try and do, and trying to explain also to the medical staff that there are traditional reasons why she's chosen to do it this way. She just wanted to do this birth as natural as she can, but with as much tradition that, that was in, she tried to put as much traditional as she can into her birth. But when we got to the hospital, everything that she wanted was, set aside by the medical team. And they immediately tried to push her for vaginal birth after C-section. And no, they immediately tried to do a repeat C-section, and she put her foot down. She's like, you cannot force me to go to have a C-section. I prefer to wait for a while. Everything is fine. And then of course the talk between the nurses and the doctors at the desk started going, and I can overhear it. And there was comments about her BMI. There was comments about her culture and her identity, and which was really upsetting. I can understand a lot of French, but I also can't speak a lot of French. So I was very, very happy that she had stood her ground for as long as she did. She came out of the birth, of course, actually needing the repeat C-section, but she felt empowered that she actually stood up for herself. And, it was an empowering experience at the end, but hearing the medical team discuss her behind her back, and a lot of it had to do because of her nationality or her culture. And that was really disheartening to hear, even when they do see other First Nations or Indigenous women coming through the hospital. That was the main topic right there. So yeah, that was a bit disheartening, but
yeah. Thanks for sharing that, Mandy. Ellen, do you want to talk about a time when you yourself or you witnessed someone not being seen or heard?
Yeah, I mean, I would focus more, I think, on the not seen, because as an actual person or as someone who has agency for themselves. And just alone in the last month, I've heard of 2 situations where women are in labor and or in the OR, and they've been forced by coercion and manipulation to undergo having their their tubes tied, and forced sterilization, coerced sterilization. So that's just in the past 2 months. And it is something certainly that a lot of researchers are looking at. But I think this happens very silently and quietly all the time in institutions specifically around that can actually get away with having that power dynamic. And some of it's being brought forward now and spoken of. So that's really great, but it's just something that just is simply not acceptable. And it's happening all the time to Indigenous women and community. As a student, I saw a Black client be used against her ask as by the OB, and he moved, she was lying. She was transitioning from first to second stage, and her baby's head was asynclitic, and they moved the bed up to the eyesight of every nurse, every student, everyone in the room, medical students, midwifery students, and really just used her body to teach and to examine and talk about what kind of forceps needed to be used. And that's stayed with me for 15 years. It was one of the most terrible things that I've witnessed. And so these things are happening all the time. And that was one of my examples that I thought through around some of the things that I've witnessed. There's many more, but I think those ones are ones that come to top of mind.
I've got some stories. But I'm going to tell some different stories because I think that the client-centered stories, we could probably sit here for the next 3 hours and just tell stories of experiences of seeing clients or pregnant people be, erased or overlooked or discriminated against by the healthcare system. And you don't have to look any further than some really public cases that are in the news. If you don't know about Brian Sinclair or Joyce Eshkwan, look those cases up where the healthcare system seriously discriminated against people and it cost them their lives. But a couple of stories that come to mind from my experiences. One was, specific to the work that I'd been doing in a major academic teaching hospital in Toronto to bridge more knowledge around Indigenous culture, cultural safety and cultural awareness, and the work that we were doing as Indigenous midwives within that space. And we had a family who were smudging and they were getting close to the time of the birth, and she was having an unmedicated birth, but in the hospital. And so this smudge smell, burning of some traditional medicine, sage in particular, was present on the birthing floor. And I was a backup midwife, so I wasn't ready to go into the room yet. So I was just standing at the nursing station. And the chief of anesthesia at the time was there as well. And a senior resident walked in with a group of medical students. And someone asked, "What is that smell?" And the chief of anesthesia in the hospital at an academic teaching center said, "Oh, they're smoking pot. We let them. It's the Indigenous way of relieving pain." And my jaw hit the floor. And this is the reason that we need cultural safety training within the hospitals to be mandatory for every single healthcare provider that is out there, because this is unacceptable for a teaching hospital to train discrimination to the upcoming medical healthcare providers who are in training. And so fortunately I was there to intervene and to actually set the stage right and to offer more education and knowledge to this group of learners. But I was completely floored and was able to take us up to the senior leadership within the hospital. Another example is me in my role as a leader. And so some people will know that I was involved in the leadership of the development of the Toronto Birth Center. So it was a pilot project. It opened up in 2013. And when we were first working on the development of this birth center, there were lots of different groups within Toronto who wanted to put forward a proposal for this birth center. And they all kept coming to me to say, well, we want to have a, an extra door for the Indigenous, or we want to make sure that we do something, we make a room for you, or, and I was, I was like, I'm working to build our own birth center and our own proposal for this. But we've thought through a lot more things than you have, because we've been working on finding safe space for our pregnant people and our pregnant communities and birthing families for a really long time now. And so it came around, and we had these different group meetings of midwives from Toronto, and there were about 100 midwives at the time. And we said, why don't we lead this? And why don't we make the space open for everyone, but we'll use an Indigenous framework for the birth center? And there was a lot of people saying, yes, this is a great idea. And we had, some great allies within the room. And this prominent, senior, well-established, well-renowned midwife said, okay, we can let you lead the development, but once it's up and running, we need the best people to lead it. Implying that I was, as the leader of developing, was not going to be equipped to actually lead the ongoing running of this practice, because somehow I was incompetent because I'm Indigenous. And it was really remarkable to me, because this younger generation of new and emerging leaders within that room really stood up and were the strongest allies I've ever seen, and the strongest allyship I've ever seen, of standing up and saying, no, actually, that's not acceptable. And we're standing behind and beside and in front of Sarah to protect her and to actually make this happen, because this is a really great opportunity for us to realize equity within the healthcare system.
Thank you for that, Sarah. Meredith, do you want to take us to the global sphere? And then just a note for the AV after that. Can you play the pre-recorded message from Vaginal, wherever you are? Well, you can hear me, so.
Sure. So we're going to be hearing from Vaginal, and she'll be relaying directly her response to this. So there's nothing more that I want to say. I think she can speak for herself.
In most of the communities in Tanzania, it's from the story about the delivery. She had a baby at the age of 20 years. But the attention comes that in the moment of her giving birth to the first baby, it was a moment that he was nearly losing the life. And she explained to me that she had a pregnancy out of the marriage, and this is ashamed in Tanzania. And she started experiencing the labor pain, and the first one to be informed, it was in-laws. And the in-laws decided to be closer to the lady. And as the time goes, the labor pain became serious, and she asked them that now I think it's a moment to go to the hospital. And the in-law said to her that no, you should not go because it's yet, and if you go there, you'll use more time until you give birth. So instead of just wasting time at the health facility, you need to wait here until the last moment that you need to give birth. Well, as time goes, that lady experienced the numbness of the lower extremity. So from the waist to the legs, she was experienced numbness. She decided to run away to the health facility, and she decided to go almost 60 kilometers from where she was living to the regional hospital. The moment that this lady reached to the regional hospital, nurses, healthcare providers, they were asking themselves and asked the lady, where were you? So they didn't see that it's emergency and that the lady should receive serious attention. Out of that, they were complaining that you delay, and they decided to attend other mothers who came for the delivery and left behind that lady. And the reason, because she delayed to come to the health facility. At the end, that lady ended by having cesarean section. But so that is among one example of many women who we don't know that they are being pushed by in-laws to make a decision that is not right to them. So the issue of respectful health services for maternal health, it's not only at the health facility, but it is started at the household level, and it goes up to the health facility level.
Okay, thank you for that, Vuano. We've been talking a lot about what is the current status of things. So let's start talking about what could be and what should be. Let's talk about reconciliation. Mandy, what does being seen and heard in the moment of birth mean to you or the families that you work with?
Well, it means empowerment for them. You know, that's the biggest thing. I've just recently been at a birth where, you know, she struggled with the idea of, you know, this is her second baby in 13 months. She's 16 years old. She, you know, just having an extremely hard time thinking about labor and how she'll get through it. And she still remembers those kind of things. But having the team that I had been, that I worked with that night, they were very culturally sensitive, the doctor, the nurses, and this woman had she had a beautiful birth where she worked really, really hard. You know, we had smudging in the room, and you know, her partner was speaking to her in the Algonquin language. When the baby was born, you know, the partner was speaking to the baby in the Algonquin language, and everybody in the room just stood back and they were like, oh my God, this is so beautiful. And when I debriefed later on with the client and I asked, you know, how do you feel? How do you feel about your birth? And the joy that she felt in her, you know, just within her was amazing, because she got through this, she's 16 years old. She got through this very fast, intense labor. And it was just so empowering for her. And I keep saying empowering, but it is. You know, she was just like, I can't believe I did it. You know, a lot of help, of course, came from me and the support, and just the offering to do the smudging within the room, and the speaking of the language while she's birthing was comforting for her. Because it's her first language, right? Like the Indigenous language I don't speak, but her partner was speaking, and I can understand quite a bit as well. But just that experience alone you know, I like just keep calling her my rock star, my superstar, because of how well she did. And she talks about it as, you know, it was that incorporating of the language and the culture within her birth that really helped her get through. It was, you know, it was a great experience for that. And I hope to see many more of those experiences as we go along. So,
Yeah.
and that's been my goal. This is what my goal has been, is to, you know, is for women to feel safe in their laboring environment and being able to use their culture and their language within their laboring environment. And it finally happened, you know. So I just hope to continue that, you know, this practice and be able to provide that for our women and our families. Mhm.
Ellen, do you want to share a bit about that? What does it mean to be seen and heard? And if you want to like broaden that a little bit too, you can talk about it in the different contexts that you've worked in. What does that look like?
Yeah, for me, it always goes back to midwives being interveners in practices of child welfare and taking babies away at birth. Really, well, that's what grounds the work that I do, that centers me, and wanting to intervene in that colonial practice of removing infants from their birth mothers. In Manitoba, for example, we know that 95% of the kids in care of the state are Indigenous, and yet we're, you know, anywhere from 3 to 5% of the population. So that just speaks, you know, volumes of all these, you know, children and babies that are being taken from their birth mothers. And so that's the way that I think about midwifery, is that this is what drives me, honestly. It's just more and more midwives need to be around women in the birth. If there's resources in the community to be able to pull in resources for that, like a circle of care. So it may be midwives and social workers, it may be shelter and housing, mental health and addiction support, all these things that are these people have to be trauma informed. They have, you know, court workers, they all need to understand where Indigenous people are coming from in order to be supportive and helpful. And so when we're standing at the bedsides of women, babies aren't getting taken anymore. I mean, there's extreme examples, but so this provides continuity, families staying together, and also to what Mandy spoke of, was really that opportunity to you know, rather than being taken from our culture and removal and assimilation of our identity into the non-Indigenous community, these are the things that are lacking and that people are thirsty for. They want to go back to understand where they're from, who they are, their identity, all those things that are wrapped up with that. And there's ceremonies that come from their ancestors and their ancestors in what we call time before time. These are things that have come up through our cellular memory. And what I want, you know, what I've always wanted is that safe space that, you know, our teachings are that we're not to have stress during pregnancy as much as possible. And if we've got child welfare coming into our homes and looking at our cupboards and saying, oh, you don't have enough food, or your housing isn't good enough, that's extremely stressful for the intrauterine environment and for the baby that's growing in there. And if we can start to minimize these kinds of things that are happening to women in pregnancy, and that they can then begin to understand who they are, and we can keep families together. This is how important Indigenous midwifery is, and having Indigenous midwives and intervening in those layers and layers of grief and loss and intergenerational trauma that we've experienced. We're starting to see, like Mandy said, like these births that are happening that are just so supportive and really, really important, so that those layers of grief and loss aren't happening to the extent that they are.
At one point back in, I think around 2016, 17, 7th generation midwives were partnered with an academic research institution, an Indigenous research unit, the Well Living House within St. Michael's Hospital, to undertake a population health survey in the city of Toronto. And it was a really kind of wide-reaching survey. It was not specific to perinatal health, though we did have a lot of good perinatal health questions within it. But one of the questions, so we tried to take a holistic strength-based approach, but we did ask people about their experiences of discrimination in society, but also experiences of discrimination by a healthcare provider. And half of the population had experienced discrimination by a healthcare provider, which is way too high, right? Way too high. But one of the findings that we found was that people who had experienced discrimination by a healthcare provider were 2.5 times more likely to not access any prenatal care or only access prenatal care really late in their pregnancy. And we know there's a reason for prenatal care. It's because it improves outcomes. So how do we have good outcomes if people are too scared to go and see a healthcare provider to begin with? It has nothing to do with you as a healthcare provider in front of them, potentially. It's their experience that makes them apprehensive and reluctant to even go in the first place. And so we have to address the system change. We already know that, and I will keep harping on that for as long as we need to. But for me, what people need is to feel safe, which we heard from both Mandy and Ellen, and I'm sure is like the same kind of piece, right? But people need to feel safe. They need to feel like they can be themselves, and that they have everything that they need to take care of their families, right? To take care of those new babies, those faces that have just arrived into this physical world, and to take care of their families in a way that gets us from like just surviving in this world to a place where we can start thriving in this world.
Do you want to talk about that just a little bit more in the context of like some existing partnerships or relationships or new innovations that are moving us closer to that?
Yeah, I mean, like when we support investment in Indigenous people, in Indigenous innovation, Indigenous leadership, right? Like, I can't remember, I think Ellen, you were like, governments and funders should be saying, what can we do to support you? What do you need? Rather than us, big borrowing and stealing just to like scrape together some semblance of a program or service that's not meeting our priorities, but rather that, like, how do we work with the community? Say, what do you need and how can we do it? When you support Indigenous leadership, when you bring Indigenous visions, perspectives, ideas, relationships, one of our biggest assets within Indigenous communities is our social networks and our relationships and our understanding of how important relationship building is in the context of healthcare or any system. And so I think that when you support that community-driven innovation, then you get programs and services like Indigenous midwifery that can really be transformative and start being that little thorn in the side of the government and the system level, kind of funders and gatekeepers to start seeing how we can move in the direction where people can really get to that thriving space. And there's some phenomenal things. I could stand here all day and again talk about some of the really amazing system innovation and midwifery innovation and health system, healthcare innovation and perinatal health that's happening. Not just within Canada, but even globally through my networks within Grand Challenges Canada.
I think maybe we can pick up on that a little bit more in the next section of questions. I just forgot to cue the audio. So the AV, sorry. So the next question, Vani is gonna, there's a pre-recorded response to it. What pathways and approaches are you seeing that are working to center women's pregnancy experiences in Tanzania on their voices and preferences?
To increase health facility delivery by women needs to be improved through strengthening service delivered to women. This should be making the whole facility to be women-centered. There's a number of actions that propose to be done. One includes to improve the quality of maternal health care with a strong focus on respectful care as one essential component of quality of care. The second be emphasize the right of women to dignified, respectful health care throughout pregnancy and childbirth. And the third one, to involve stakeholders in improving the quality of care. Involving of stakeholder include involving women and men as the agent of change. In World Vision Tanzania, we have two modules that shows promised way of improving the issue of gender equality. One that was being used in the project that I was working before, it is Medcare. This module shows the positive changes of the positive attitudes of the men towards supporting maternal and child health care for mothers from the pregnant time to delivery. The second model that has been used in World Vision Tanzania is the channel of hope, particularly for maternal child health, and other was focused on gender. And this has been shown to improve maternal health care being done by the community and by the household members, and also improving the issue of gender equality.
Thank you for that, Wani. We have a little bit of extra time, so I'm thinking of a few more questions to add. Sarah, you want to say something?
Yeah, I'm just talking about like the system level solutions and different pieces. And Ellen, you'll be familiar with this as well, as we need systems that are accountable, that are representative, so that they're accountable to the right people, that are self-determined, and that are embedded in different governance mechanisms and structures. Sometimes even the biggest barriers are within the gatekeepers and the governance and mechanisms and structures. And this is across our health human resources, our education and capacity building programs, the programs that get delivered, the strategies that are developed within organizations or even within health systems, and also, as Ellen alluded to earlier, like within the data governance and data sovereignty pieces, and how do we connect and allow communities of whom the data is about make the decisions, interpret the context of those things, and then decide what is it that they want to do with that data and how it can be used to benefit the communities themselves. So it's like building these collaborative and representative leadership models. And we kind of joke, we called it the first people's first approach, right? And so if we can figure out what are the solutions to supporting the community that has the worst health outcomes, is winning all of the wrong races, and is most disadvantaged in Canada, and we're the first peoples, then actually we're going to make care better for everyone, right? And decolonizing a healthcare system is not an easy task. Decolonizing the government, wait, okay, we're going to get there. We're going to get there. I have a dream, but it's like decolonization and reconciliation, and people are thinking that these are the tools that we need to get there, or there are the outcomes that we're trying to get to, and it's like no. Decolonization is the tool for equality and for getting to that point of having an equitable system and solution globally. We've all been impacted by colonization. There's like very few countries that have not been colonized. And so how can we use those decolonization tools and structures to achieve better equality for everyone, gender equality, racial equality, accessibility equality, and just, for everyone? We can start to remove some of those privileges and start to remove some of those privileges that people that have that shouldn't necessarily, and we can start having more power sharing. And so I think that's what I wanted to kind of highlight, was just like that decolonization, first people's first approaches, basically not last, can, I think, actually be a mechanism to get us there. But we need more people to learn and understand what those tools are, and what the emotional burden and the social burden and the cultural burden is on putting the lift of doing that work on the people who have been most disadvantaged by colonization. And so we all need to work on this together.
I'm opening it up. Mandy, Ellen, Meredith, do you want to comment? Do you want to share some of your thoughts?
Well, in my experience within the last year, in trying to develop my practice in Kitigan-Zibi, Maniwaki area, it actually surprised me on how the provincial government really took attention to my project. You know, when the Ministry of Health heard that I was, you know, trying to develop this, and what happened in my community is that myself and the Director of Health and Social Services, we kind of came to a roadblock, and we didn't know which way to go to try and get the services moving and started. And you know, we've had meetings with the midwives here in the Outaouais. We had meetings with, you know, the Director of Youth Health, and it came to be that the Ministry of Health, like the higher levels, heard of, you know, my project trying to get off the ground, and they actually ended up hiring a retired midwife in the Montreal area to start developing Indigenous midwifery care in Quebec and Indigenous doula programs in Quebec. And her first priority was my project. So she approached us, and we started working together, and the amount of support that I've gotten from the province of Quebec and the Ministry of Health has been outstanding. Definitely not something that I was ever expecting, seeing, you know, as though there's often a contentious relationship between the First Nations of Quebec and, you know, the province of Quebec. And it's just snowballed within a year. You know, we met this midwife, and then it snowballed into a fact where I'm actually practicing now. And it was the help of the provincial government, and which surprised me quite a bit. But it goes to show that, you know, when you have people out there, or people, you know, in the higher levels of government who want to help, you know, the Indigenous programs, and who want to see this happen, you know, projects that are, you know, as you see, out of reach can actually be reachable. And forever grateful for the support that I'm receiving from the province of Quebec and the Ministry of Health. So to me, that's kind of a system change right there, you know, and hopefully sometime in the future we can, you know, it'll get to the federal level as well to fund midwifery programs federally within communities, within reserves, within reservations. So I know it's happened a little bit, but, you know, our final goal is for funding to completely come from the federal government, because I'm an Indigenous midwife servicing Indigenous families of the area. So that's the future goal. Hopefully in a few years that will happen, but just to see that system change in the government of Quebec to actually help an Indigenous project get off the ground was quite amazing.
Ellen, do you want to talk about some of the changes you're seeing? You know, you sit at a lot of different tables at the, you know, at the provincial level. What kinds of changes are you seeing? What's making you feel maybe a little bit more hopeful these days?
Yeah, that's a really good question. I don't know. I feel like one of the questions that was asked was around, do we want to partner with mainstream medical systems? And I see the site of harm often is in those larger institutions like hospitals. They're not necessarily at a home birth where there's an Indigenous midwife, or, you know, smaller institutions, I guess you could say, like the birth center. You don't see that. But so I say to myself, how do we decolonize this? Do we really want to partner with mainstream medical systems? We still have, like Mandy said, we still have that reliance on the federal government and on the provincial governments for funding. But how much reliance do we need? Because we know for me, it's a door that I'm knocking on, and it's never going to be opened. And it's about accountability. It's about accountability for the racism that exists within hospitals and within mainstream institutions, educational institutions, anywhere. And so far, there isn't really a lot of understanding about how can these institutions be accountable when the harm happens right on the L&D floor, and you know, there's all this racism that's happening. everywhere. So I try to figure out ways like, how do communities, how do women, how do Indigenous midwives self-determine the kind of care that they need? Because I just find no matter what circle I'm sitting on or where I'm going, the door, it's really hard to crack that door open. And what that cracking that door open means is that those people that have the power and hold on to it, like, let's hand it over. Let's have an equitable and relationship of reciprocity, so that we can stand together and share the decisions that are being made, because we are not yet at those tables where we can actually make the decisions, those critical, large funding decisions, for example, or things like that. We're not there yet, and we're working really hard at it. And I think a little bit later on, I can talk a little bit more about some changes that happened recently in Ontario, or is about to change. I think the question's coming along a little bit later. To give an example of maybe where we have cracked the door open a tiny little bit, but we got a long way to go. I don't mean to sound so like negative. There are like positive things happening, at least in Ontario, where we do have a funding envelope for Indigenous midwifery programs, but it's just a start, and there's a long way to go.
Ellen, we have more time. I would invite you actually to go ahead and share your example.
Okay, because it was going to be asked later on, but the question was going to be about what are the changes that we've made in some of the legal aspects of how midwives practice in Ontario. So Ontario is a very specific province in that we have what's called an exception clause in the Midwifery Act. So we have I like this exception clause a lot. And what it is it says that if communities determine that there's a midwife in their community that's Indigenous, that has had the education and has the responsibility to be a midwife, that they can actually call themselves an Aboriginal midwife and not be registered with the College of Midwives of Ontario, that the community is the governance for those midwives. And they've been doing that now for over 20 years, around between 20 and 24 years now. Aboriginal midwives who choose to go that route and don't want to be registered and want to work within their community. But they've been working without the support of a healthcare system, in the sense of where they haven't had what's called OHIP billing numbers. So that means that all registered midwives in Ontario have billing numbers that they can use to order, like for referrals to physicians, for blood work, for ultrasounds, things like that. And Aboriginal midwives have not been able to have a billing number because they're not registered with a college. So the Aboriginal midwives came to us and said, can you change this? Can we obtain a billing number so that we can at least, we're still governed by our communities, but we want to be able to at least provide pathways so that we're not disadvantaged in the system. And I can give some examples of how midwives are disadvantaged in the system who don't have billing numbers, and also clients. So for example, up until now, Indigenous clients have had to go to extra appointments in addition to their trusted midwife to ask for a requisition for blood work and ultrasounds. So they have to go to another appointment to get the physician has to requisition that work and go before they're allowed to go to get their ultrasounds or any blood work done. So clients would then have to pay for their own transportation to do that, go to another appointment, they don't necessarily have childcare, they don't necessarily have vehicles to do that. So it's a lot of extra work that Indigenous women have had to do. And I think someone spoke to this earlier. A lot of times they don't want to go to an unknown physician because what happens there is that they get treated they get treated not well, they get treated through a racist lens, and then they don't want to go to prenatal appointments. When they don't go to prenatal appointments and they show up, then they have, then people call Children's Aid because they said you haven't had enough prenatal appointments. So then the baby gets apprehended. So there's this whole multiple harm circle that happens. Another thing that happens without billing numbers is that clients have gone to their physician and the physician has done the blood work and looked at it and said, you need, maybe you might need some iron supplements. And eventually the blood work the results go back to the midwife if the physician remembers to do that. And then the midwife sees it and says, oh, you need iron supplements. And so this client is actually getting iron supplements from her physician and from the midwife, which obviously can cause issues. So there's tons of issues. There's like when clients go to the physician, they might undermine the midwifery care and say, come and, work with me. Midwives are just over here. They're not really part of the medical system, or you shouldn't be going. And sometimes the critical blood work comes back and the physician sees it, but doesn't get it to the midwife in time for the birth. So I don't want to go on and on, but there's just so many things. So we've been able to move that forward and have a couple of regulations changed in a couple of the acts that we have in Ontario. And so that very soon, Aboriginal midwives will be able to have billing numbers, even though they're not registered. The ones that choose not to be registered, they'll be able to have a billing number. And then the client care and the midwifery services will run much more smoothly. And it's just going to be a benefit for everybody overall.
Yeah, thank you, Ellen. Meredith, do you want to talk about some systems changes, some innovations that are happening in the global sphere?
Sure. So I think, one of the things that's really struck me through the presentations that have been made by the Canadians is there's a big focus around empowerment and also around individualized voice. So despite the fact that we're talking about bigger systems change, there's a lot of discussion also at an individual level. You talked about the young woman who gave birth and her partner speaking to her and their baby in Algonquin. And I think that's such a beautiful story. And I think it's there's at a global level, these same kind of systems exist. So right from the personal and that within that woman, within her family, within the community, and in institutions, and in this case in hospitals and in community health facilities. So I think when we're talking about systems change, we have to look at all of those different levels. It's not just at the institutional level. It's also at right down to the very personal level. And organizations like World Vision Canada work with communities, and we work with providers of care. We don't provide care directly ourselves. And one of the things, in order to try and impact on those systems at all of those different levels, we've recently identified 5 different things that we're trying to do in all of our interventions and all of our programs and in our partnerships. And the first one is a real focus on partnering with women and girls, and this idea of building up the capacity, the sense of leadership, ability to negotiate, ability to voice one's ideas, build agency around setting goals, around contributing to to things going on in her community and in the economy. And this idea of sort of individual and collective agency all together. And that's really important. And one of the things that Movano mentioned is this idea of sort of the broader context. So what she didn't share, but did talk to us on the phone about, was the fact that this woman that she related the story about was surrounded by women in her family and in her in-laws' family. And one of them said, "I've had 14 children, so you need to listen to me. I know what birth pain is all about." And because this was this woman's first baby, and it's also, it's not just working with individual women and girls about their own lives, but also about working with women and girls in the community and ensuring that understanding of individual agency and individual voice is just as important as collective voice. And so that's the first one. The second one is very much linked to that, is around elevating the social value and position of women and girls. And kind of, I don't know if it was Ellen who gave the story of the woman who was pulled up on a bed and there for everybody to kind of observe, like she was some sort of specimen. And I know in a medical community, there's that specimen has probably a very specific meaning, but it's so invasive and so really relegates her not not to a person. It takes away her personhood. And I think that part of elevating a person's value in their community is about also, it relates also to these kinds of situations where women are being ignored and relegated to being simply a medical specimen in some cases. The third one is ensuring that gender equality and sort of ensuring that empowerment of women and girls is not only something that we're doing as like one component of any kind of particular project that we're doing, but is also integrated across like the entire project. So it's integrated sort of one thing, you know, very specifically that we're doing, but also in all of the elements that we're doing. So for example, whether it's be curriculum development or training of senior administrators, their understanding of gender equality is there as well, that we're conveying that importance. So that's another area. And Wavano talked about this, the idea of engaging men and boys as well as faith leaders. And World Vision works with a number of different approaches, but one of the key ones that we work with is this thing called Men Care, which is really working with men in the community to ensure that they have a platform to unpack gender inequality. They have a platform to unpack negative behavior patterns that they are contributing to. This is important also for adolescent boys. And so these are a couple of like some of the ways in which Men Care works. It's an online, I believe it's even open source, tool. And also she mentioned Channels of Hope, which is a program that works with faith leaders. So faith leaders of multiple different faiths, looking at sacred texts and helping them to unpack what exactly does that say about women and men and those who are non-binary and their inequality, and working through sacred text in that regard, because it's so important. Because honestly, someone says something at the front of a church or a temple or a mosque, and everybody agrees, and that's what everybody's going to go and do. So the amount of power that those individuals have is huge, and that's something that we've identified as being a really key way to influence communities. And finally, is that idea of fostering an enabling environment. So not just working with, you know, women and girls, or working with their mothers-in-law, or working with their partners or their faith leaders. It's about working with, you know, the laws in the society. It's about working with those social norms in society. It's about changing policies and community practices. So ensuring that there's you know, that also includes working with facilities and working with kind of facility protocols. And I think that these are, you know, creating that enabling environment is something that's, you know, we often talk about that and throw that kind of term around, but it's so key. And the enabling environment can be almost anything, because you can be, you know, chugging along, thinking things are well, and then just one person's comment, like for your example of being in that setting where that person said to you, how, well, we'll make sure we give this over to somebody who knows what they're doing. And that, you know, everything can be going so well, and then one comment, because there's so much history, right? There's so much ingrained inequality and sense of lack of worth for some people, that can really bring them right down and can undo everything else. So I think that the idea of working on enabling environment is frankly one of the most important ones, because there's so many different nooks and crannies that you can get into there.
Great. Sarah, do you want to talk a bit about what an enabling environment looks like, and like some of the innovations that you're working on Grand Challenge that really move that piece forward?
Yeah. Well, I mean, I really like what you said about, you know, there's multiple levels that we need to address this at, right? So there's the individual level where we are supporting that patient-provider relationship, addressing racism, and being, you know, able to train, you know, existing and future generations of healthcare providers to provide anti-racism, you know, healthcare services, but also looking at it at the organizational level and the system level. And at the organizational level, you know, so many, like especially in Canada, but I think it's a global issue, like hospitals and organizations are set up to be provider-centric. And patients have to access the services that, meet the needs of the providers, because they're, the most important person in the room is presumably why that's the way it's been set up. And so how do we create more trauma-informed and inclusive spaces, and including that gender affirming spaces, right? We have to get away from that binary and even that trinary of, women, men, gender diverse, and then what's the in between, because it's a spectrum. And so we need to actually start shifting and moving into the space where everyone has a role in equality. And then of course the system level pieces, which I've already kind of talked extensively about. But I think that, what we need kind of more globally to create these spaces is, of course, education and training. We need to keep ongoing this journey of learning, unlearning, relearning, what the impacts of, what we've been taught by society are. We need to have some more design thinking, opportunities for design thinking, and bringing more co-creation into the systems that we're trying to redevelop and to rethink. Of course, we need some policy mandates, because not everyone's going to come on this journey with us. I mean, we're preaching to the converted here. And I know that everyone here is because they have an investment or a stake or an interest in gender equality and equality just generally for our world. So how do we bring those other folks along? And sometimes it's going to take mandates, incentives, or actual policy change that requires that. We need time. Colonization didn't happen overnight. It's going to take a few generations, and seventh generation midwives was named after this premise that the seventh generation is when things are impacted the most. The decisions we're making now have their biggest impact 7 generations from now. And the context that we have right now are because of decisions that were made 7 generations before us. So it is going to take time, and we need to be patient. This is a lifelong journey what we're on and we're embarking on. So there's no need to rush to address, like Ellen says, the low-hanging fruit, because what we're doing, it's for those faces yet to come, so that they have a land that they can live in that's healthy, that they can have communities that are safe, and that they feel welcome and safe and able to be themselves. And then lastly, it's going to take investment in this. And so we need to start shifting where are things being invested in, and we need to get out of this kind of capitalist mindset and start investing in more, more ideas and more services. And so, we are funding a lot of really cool innovations. We have, digital health apps that are looking at how can we integrate Indigenous health knowledge and pregnancy knowledge with mainstream population health knowledge. There's a role for everyone to kind of integrate these systems and try to advocate for those things so that people are motivated. Like, pregnancy is the time when people are the most motivated to take care of themselves and to take care of their families. So what are we doing to wrap around all of those supports so we can improve their health experiences and improve their health outcomes along the journey? How do we create mechanisms for community safety, right? Supporting people with lived experiences around discrimination or oppression or sex trafficking or like assaults and violence in their communities, and how do we support them to bring those voices to the forefront so we can understand what the real solutions are, get upstream from what we think is in front of us, because the root cause of those things is probably many steps behind that. And so we need to start having those really difficult conversations around what is all of our role. If we're not part of the problem, then we can't be part of the solution. So really taking that thoughtful look at what you're doing and how you can make the change, and then support kind of advocating, bringing those voices together.
Amazing. We have about 7 minutes left. So I'm going to ask each of the panelists to just share like a final thought. And if we have any time left, I might just ask like folks in the audience if you have a quick question or just a comment on something new that you heard today, because I think it's like important to acknowledge also that, yeah, we're probably talking to a converted group here. But it would be just interesting to hear if anyone heard anything new that they can take with them today, in their little bundle in terms of the work that you do in the areas that you influence. So maybe just a quick round from all of the panelists. I'll start with you, Meredith.
Sure. I really appreciated this opportunity today to chat with my fellow panelists and these amazing women. And I think when I think about sometimes it's difficult to wrap one's head around what's happening globally and in far, far away places all over the world. And the little window that we got we got to look through today was into Tanzania. But Tanzania isn't unique, and many of the challenges that women are facing in Tanzania are challenges that women are facing also in Canada. And I find that we didn't even, Wavano and I didn't even discuss decolonization of aid and decolonization of the healthcare system in Tanzania, and that is something that's equally could take hours to discuss as well, and it would be an equally interesting panel. But to me, what I find interesting is the number of similarities in terms of women's experiences to greater or lesser degrees around different elements of inequality. So in Tanzania, it's I think gender inequality is perhaps the most profound and pervasive inequality that exists. But there's other inequalities there as well. There's inequalities based on ethnicity, based on religion, on other factors, and certainly there would be around gender identity and sexual orientation. And so I think when we look at and we try and compare that with the Canadian context, there's the number of intersecting challenges that women are also experiencing here. To me, it just reminds me that the world is small and that we have so much to gain from sharing with one another and sharing in these sorts of spaces and bringing those global perspectives into our national discourse and into these opportunities to look and consider and learn. So thanks.
So my thoughts here at the end of the discussion is that, for myself, I've always just seen, I don't want to say always, but, I'm very, very familiar with the inequalities here in Canada, especially with the Indigenous community. And of course, we need those policy changes and we need those advancements to help that those families within our own country, and going through the discussions that I've had going way back into midwifery school, there's always that talk about the inequalities, of course, of other countries and other countries that have Indigenous people within their country. And as you're saying, the inequalities are very similar, and they're just looking, it's the looking forward to trying to make those inequalities equal. Hopefully someday that will happen. Hopefully that, we can convert the unconverted, and it may take a while, but it'll get there. It'll get there.
Oh, I don't know if you can hear me anymore. It seems like my mic is off. Can you hear me? Okay, Ellen, can you hear me?
Yeah.
Okay, yeah. Ellen, do you have anything, last words or thoughts you wanted to share?
Yeah, we talk about non-Indigenous people being our allies. I feel like we need to move from allies to accomplices. It's going to be a long haul, but people that are actually not just saying Indigenous people, you need to do the work or tell us what to do. I think someone else alluded to that already, that they need to actually be doing the work. They need to be figuring it out how they can support Indigenous communities that are draining on all of our resources all the time. We're exhausted. We're always being called to many venues and forums, and we love to do that work. It's just there's only so many of us, and I think what's important to me that I've also looked around and seen healthcare in the United States, where there's a privatization of healthcare, and in Canada, it's from what we can see, for the most part, it's not privatized. And I remember seeing, like, talking to a midwife down in the States, and she was making $60,000 US a month because she was serving clients that were willing to pay her quite a bit of money for a birth. But what she had was a circle of care around her as a midwife in the community. And if we go back to Indigenous communities back in the day, those midwives had a circle of care around them too. they had people helping cook food for them and you know, housing and all kinds of those kinds of supports. But you know, there wasn't that exchange of funds to do that. But midwives need support too, and I think we need to figure out how we're going to create a system that midwives aren't just sitting alone in their communities without the kind of supports that even we see physicians have in hospitals. They have all kinds of supports. We need to start looking at that and figuring out how we can support the integral. We also know there's not enough midwives, Indigenous midwives. We're looking, you know, NACM's doing some super hard and amazing work at education and training of Indigenous midwives and community. We're trying to support that work locally in Ontario, and that I really would like to see those accomplices work with us. We have, you know, the government in years past has separated us into these reserves. We have 600 reserves across Canada. We're all like doing separate kind of things, and we need to join together. It's like, what are deliverables? What do they mean to Indigenous communities? We need to actually come together and join hands across this country to be able to figure out the systems changes that need to take place. More voices are going to get heard more. And I think that's where I'm looking towards, is more collaboration within Indigenous communities and among Indigenous communities, but also bringing in, I think Sarah talked about that as well. If we can make it better for one community, we can make it better for everyone. So investments instead of just these, you know, people are happy to have short-term investments and then, you know, everything's great because they get to be seen and heard, but people need to shift their thinking that we need longer term investments that last years. And I know there are some out there, but we need more. We need more of that kind of thinking to take place. So yeah, that's the last words that I have. And thanks for inviting me to be here.
Yeah, thanks so much for joining us virtually today, Ellen. Sarah, do you want to close this? I know I've got a big red light blaring at me here, but you know what? I'm going to do this anyway. Yeah.
Just to say, I mean, everything's intersectional, right? So there's a role for everyone in this. And like, you know, you can see like all of these different systems and connections and pieces are interconnected. And some of my early teachings were around, you know, as an adult, like, what is my responsibility? My responsibility as an adult is to use the skills, talents, and experiences that I have. And so I have seen myself as being in service to the community, and a bridge is where I find myself the most useful, is to bridge between what is mainstream and what is happening either in, you know, innovation systems, investment systems, healthcare systems, and bridging that so that the community and the individuals that are receiving those things have the best opportunity to, again, go from surviving right to a position where they can be thriving. And so thank you so much for the opportunity to chat with you all today. It's been a fun conversation. English.
Thanks, everyone. Great. Thank you.